This video wraps up Chapter 11 of OEC 6, looking at altered mental status. And in this case, we'll look at the management of a couple of the types of patients we might encounter with altered mental status. In particular, we'll talk about management of a transient ischemic attack, and if that's elevated to a stroke, the management of hemorrhagic and ischemic strokes both. So some of the key terms that we'll encounter, again, just thinking about strokes and the couple of different types. We'll talk a little bit about hypoglycemia and the management of a patient with diabetes too. So we'll begin with management of a patient with AMS. And one key piece is to just check the patient's airway frequently. If their altered mental status progresses to lack of responsiveness, keep in mind that the most common obstruction to the airway is the tongue. And so if the patient progresses to becoming completely unresponsive, consider an NPA or an OPA. Trauma may have produced the neurologic injury, but if you can rule that out in terms of MOI, you're dealing with much more likely a medical sort of a situation. Now in hypoglycemia, we can provide oral sugar to any diabetic with altered mental status. Make sure that this is done only if they're responsive enough to swallow so that we don't introduce an airway issue. For a patient that has a history of diabetes, we'll assume that the patient is hypoglycemic because low blood sugar can lead to irreparable brain damage. If they have too much blood sugar, you're not going to cause any further harm. Normal range, remember, is 80 to 140 milligrams per deciliter. Well, if they're running 400 and you give them some blood sugar and bump it to 450, you really haven't made that patient much worse. On the other end, though, if their blood sugar is too low, this is a key treatment. Make sure, once again, that the patient can swallow because we don't want them to aspirate and end up with pulmonary problems, and we don't want to, of course, interfere with the patency of the airway. Now, it's possible that a family member may be carrying a glucagon kit and trained in its use because they're used to having this member of their family with diabetes, and so check with them, perhaps as part of your patient history, if that's coming from a family member because the patient has an altered mental status. Now, many ski patrollers carry in their vest oral glucose, which can appear as tablets or sugar packs or tubes of glucose like this, or even tubes of cake frosting. Providing that to the patient, sometimes by dissolving it in water so that it's more easily consumed, is a possibility. And if the symptoms resolve themselves, and oftentimes they will, encourage the patient to consume a small meal. They probably should check their blood sugar if they're able to do that. And if the symptoms do not resolve, well, then maybe it's something else and you need to consider that. Patients may refuse transport to the hospital once their level of responsiveness has improved, and especially if they're used to dealing with diabetes because they've had it for a long time. You should encourage them to be evaluated further and then document that refusal if they don't want to head to the doctor or the hospital. If they've had a hypoglycemic episode, it's evidence that they're not controlling it well, and that's why we want to encourage this follow-up. Another possibility for AMS is a stroke, and you can improve the chance of survival by providing high-flow oxygen. Whether it's a block or whether it's a bleed, part of the brain is not getting good perfusion, good oxygen, and so providing that high-flow oxygen is going to be important. We want to protect the airway in case their level of responsiveness decreases all the way to being unresponsive, and then transport to a definitive care facility is going to be important, and it's time sensitive. In the case of an ischemic stroke, which is about 80% of all strokes, clot busting medications are very useful if they're provided to the patient in that window of time just within a few hours. Don't delay transport unless you need to engage with spinal motion restrictions, and then notify as part of your handoff that a potential stroke patient is coming. The time last well known. The onset of the stroke conditions will help again with the time window for providing clot busters. In summary, AMS is this serious problem that we may encounter, many causes, but some of them are life-threatening, and the symptoms allowing you to distinguish between those very broadly across the entire spectrum. So be very familiar with what those symptoms can be to help with your correct assessment.